This is a phase 2 trial, a single center, single arm, in which we added Nivo to the radiation-based standard of care therapy for high and very high-risk prostate cancer patients. And the way that we did this is we dosed it with 4 cycles in total of Nivo. 2 cycles were given before each of the 2 fractions of the brachytherapy, and we did that upfront before the external beam component. What drove the hypothesis for the study was that by doing the radiation combination with the Nivo in this way, we could try to avoid some of the lymphocyte destruction that we get with external beam, and additionally try to, using this ablative dose brachytherapy in combination with the Nivo, we could break down that immunosuppressive tumoral microenvironment in order to try to get a response in these patients that have historically or traditionally without this, without kind of what we've seen, have very immunologically cold tumors and would normally not have any benefit from any kind of a immune checkpoint inhibitor therapy. So one of the exciting things that we saw with this trial was that when we compared it to historical controls, patients met all the same inclusion and exclusion criteria and all treated at the same center with the same therapy, we noticed that there was an 88% reduction in the risk of two-year metastatic disease for patients that had Nivo added on as part of their trimodality therapy. Which was a fantastic, obviously clinically significant outcome of the trial. But one of the very exciting discoveries, results of the study was that we looked at the genomic profiles of these tumors as well. And part of the study was we would take biopsies at the time of brachytherapy for each fraction and then also a month afterwards, and we were able to identify some genomic signatures that were associated with early pathologic response. Sting, and PEP are just a number of these, and there was a number of immunologic signatures also that were associated. However, there was one signature in particular which was associated with early pathologic response, major pathologic response, which was the rickets immunosuppression genomic signature. And what was really exciting about this particular signature is it also predicted for early radiographic complete response too. And it was the only signature that we're able to predict for both pathologic and radiographic response like it did. So we're excited not just at the clinical outcomes of the study, but being able to identify a signature that we can hopefully use in the future to identify patients that would benefit the most from the addition of immunotherapy for the treatment of their locally advanced prostate cancer.